This presentation on analgesia has been prepared for students of pharmacology at Keele University, and if you watch it from elsewhere, you are not welcome to do so. So what we're going to do is we're going to start off by trying to understand how pain is perceived by the human body, how it responds to it, and then we're going to look at different ways in which pain can be treated, looking at some of the advantages and disadvantages with the drugs that are used. I'd like to recommend, as always, that you take a look at Golan. It provides some very detailed physiology about perception of pain, and it also goes into anesthesia in some detail, so I thoroughly recommend looking at that. Although some of the other books are pretty good as well, and Rangendale's quite good too. And if you're looking for clinical perspectives, I recommend taking a look at Bennett, Brown and Sharma. So if I said you had to look at anything, then I'd say look at Golan and Bennett, Brown and Sharma, and that would be about perfect. If you'd like to prepare for this, then perhaps you might like to go back and understand how action potentials arise. Think about how ions move across cell membranes, causing membrane depolarization, which ions they are. You might go back and look at the pharmacology of inflammation, because you're going to see that's important in pain. And then also look at the cardiovascular and GI lectures that you've received recently, because this will help you understand some of the adverse effects of some of the drugs we'll be looking at, as well as some of the cautions. I'd like to start off with a general description of the concept of pain, and I'd like to make a distinction between pain and something called nociception. So nociception is the physical process that takes place that responds to a painful stimulus. And by a painful stimulus, I mean something like banging your hand up against a table, or maybe pouring hot water on yourself, or tripping over and banging into the floor. They all create painful stimuli. And the body's response to that stimulus sends a signal up into the brain. That's called nociception. So it's the body perceiving the painful stimulus. That's distinct from pain, because pain represents how you respond to that nociceptive stimulus. And that depends upon your emotional state. So for example, if you're in a good mood, you'll be aware that you're more able to put up with, say, banging your toe than if you're in a bad mood. Your emotional state alters your perception of the nociceptive stimulus, and that then translates in how you perceive that as pain. If you're happy and in a good mood, you can perhaps put up with something better than you can if you're in a bad mood. So your ability to tolerate these nociceptive stimulations is modulated by how you're feeling. So anxiety and depression, whether you're bored, can all affect how you perceive a nociceptive stimulus, how you perceive something that sends a nociceptive signal up to your brain. And you're also going to see as we go through, if you've got any ongoing inflammation, that can also affect how the nociceptive stimulus induces pain. And you see that prostaglandins in particular can sensitize the fibers that send these nociceptive signals, and sensitize them so they're better able to send nociceptive signals up to the brain. So we can make a distinction between two types of pain. One is nociceptive pain, and the other is neuropathic pain. So nociceptive pain comes about when you actually do some damage to your body, or some damage takes place to your body, let's say, and then the fibers that detect the pain get activated. Now these pain fibers are sensory fibers, but they've just got a high threshold for activation. So they're not like the fibers that you use to feel something. If you just touch something, that doesn't create a painful signal. And the reason for that is that the threshold is a lot higher to activate the pain fibers. There has to be some damage done to the tissue to activate the pain fibers. So in nociceptive pain, there is actually damage of some description, and that activates the pain fibers, and they send the nociceptive signal up to the brain. So there's actual damage response there, if you like. That's distinct from neuropathic pain. So in neuropathic pain, you get the sensation of pain even though there may be no damage. So this may actually reflect something going wrong in the pain fibers themselves. So they could be sending a pain signal even though there's no painful stimulus causing them to be activated. There's just something abnormal in them, and they're sending painful signals even though they shouldn't be. And we also need to distinguish two other types of pain. That's acute pain and chronic pain. So acute pain is something that happens in response to a certain symptom, whereas chronic pain is something that is ongoing for a prolonged period of time. And the reason that we really need to distinguish between these two is how you treat them is quite different. So if you've got someone suffering from acute pain, perhaps the most appropriate thing to do is to take away the problem. So if, for example, someone has broken an arm or something, then maybe fixing their arm is the best way to treat the pain. If you can't simply treat the pain and take it away, then you can suppress the pain, and that can be done with a non-steroidal anti-inflammatory drug, an NSAID, or an opioid. So that's acute pain. Now let's look at chronic pain. So chronic pain is pain that's ongoing for a prolonged period of time. And how you treat that depends upon whether there's any inflammation taking place. So if there's inflammation taking place, and remember that inflammation can sensitize pain fibers to these pain signals. If there's inflammation taking place, then what we can do is reduce the inflammation. And here we could use an NSAID with the intent to reduce the inflammation. Of course, it will also inhibit the pain signal transmission, but it's helping us out here because it's inhibiting the inflammatory component. And then we could also use something like an anti-TNF drug. And we saw those when we looked at eczema and psoriasis, and you see later on how they're useful, particularly in treating arthritis. So anti-TNF inhibits inflammation. So if the chronic pain's got an inflammatory component, we can use the NSAID or the anti-TNF drug, whereas if there's a chronic pain with no inflammation involved, then it's a bit harder to treat, and really all we can do is suppress the pain, and again we can do that using an opioid or an NSAID. And in that case, it's probably better to treat the patients in anticipation of the pain. And what I mean by that is the patient should be advised to take the drugs before they experience the pain, rather than just when it occurs. That seems to provide better pain suppression. So in other words, they continually take it, or when they expect to suffer a period of pain, rather than waiting for that pain to occur. So we're going to start off with this slide looking at how signals are sent from the periphery up into the brain and how that leads to a pain signal. And we'll start off over here looking at cyclooxygenase, which during inflammation can use arachidonic acid to make prostaglandins, and in particular prostaglandin E2 can activate receptors on pain fibers and make them more sensitive to painful stimuli. So these are the pain fibers that are going to detect the pain. Here's the painful stimulus. It's some type of damage, or maybe high or low temperature, pressure, or maybe acid. All of those painful stimuli activate these fibers, and they're going to send a signal up into the central nervous system, and that's going to be perceived as pain. These fibers are rendered more sensitive to the stimuli by the prostaglandins that are produced during inflammation. As well as prostaglandin, other mediators produced in inflammation can also impact these painful stimuli. So, for example, bradykinin can actually create a pain stimulus itself, and histamine can cause itch. But the one we're most interested in prostaglandin is prostaglandin E2, which is produced by cyclooxygenase and then sensitizes these pain fibers to these noxious stimuli. Okay, so now the signal passes up this pain fiber into the dorsal horn of the spinal cord. That's meant to be the spinal cord there. This is the dorsal horn. And depending on which fibers we're talking about, and I'll talk about different fibers in a second, some of these fibers either directly synapse onto neurons that pass signals up to the central nervous system, up to the brain, or there are interneurons that relay the signal to the contralateral side of the spinal cord, and then that passes a signal up. Now, so what happens here is this signal has been perceived by the nociceptive fiber and it's been passed up to the central nervous system through this ascending fiber here, the black line. The ascending fiber has got a cell body that's located in the spinal cord, and that can actually release nitric oxide. That nitric oxide can diffuse back and activate the presynaptic neurons and increase the pain transmission signals between the presynaptic neuron and this ascending postsynaptic neuron. So in other words, the nitric oxide can potentiate this postsynaptic neuron responding to the signal that's coming from the pain fiber. And that nitric oxide is then important in a process termed wind-up. And wind up refers to the idea that if you repeatedly stimulate yourself in a painful way, that makes you more sensitive to painful stimuli. So in other words, there's a wind up of the pain response. So the pain fiber ascends up to the central nervous system, and it sends its signal into the cortex where that's perceived as pain. So you can see that the signal getting through the spinal cord is particularly important. And there's something called the gate theory of pain. And the gate theory of pain basically says if the painful signal is great enough to pass a threshold, then it creates a signal that's sent up into the central nervous system. In other words, there's a threshold for sending this painful signal up, and it's called the gate theory because the painful signal has got to get through that gate, if you will. So the painful signal is sent up to the central nervous system. It creates pain, which is perceived in the cortex, but it also sends signals to the limbic system in the central nervous system, and that's involved in the emotional response to pain. And we all know from personal experience that when you experience a painful stimuli, that can have an emotional effect, and that's because the signal's been sent to the limbic system. Now, there's also another signal, another pathway, and that's called the descending inhibitory pathway, and that's the signal shown in red here. And what that is doing is this fiber is passing down the spinal cord, and it's then inhibiting the signaling in the dorsal horn of the spinal cord. So it's preventing the painful stimuli from activating this ascending signal. So it's inhibiting the painful signal being passed up to the brain. So that can then inhibit sensations of pain from reaching the brain. And you'll see that that's important in just a second when we start to talk about some drugs. So let's look at the different types of drugs we've got. First of all, let's look at NSAIDs. So NSAIDs inhibit cyclooxygenase, and cyclooxygenase, as we said, catalyzes the production of prostaglandins that sensitizes these pain fibers to painful stimuli. So if we block cyclooxygenase with an NSAID, that reduces the production of prostaglandins, and so the pain fibers are not sensitized to the painful stimuli. So there's a higher activation threshold, and therefore the pain fibers are less responsive to pain. So you send less pain signals up. So that's the predominant way that NSAIDs work. We'll now look at opiates. Opiates have a number of effects. So first of all, they can directly inhibit signaling in the dorsal horn of the spinal cord. So they prevent the pain signal being sent from the nociceptive fiber that's coming into the spinal cord. They prevent that signal being transmitted to this ascending fiber. So they're inhibiting signaling, and I'll show you the mechanism of how they do that in a minute. But basically, they're preventing the signal being passed up to the brain, and so you don't perceive the pain signal. They also activate in the central nervous system this descending inhibitory pathway. And you remember that's also inhibiting this passaging of the signal from the nociceptive fiber to the ascending fiber. So by activating the descending inhibitory pathway, they're also shutting down the ability for this signal to pass from the nociceptive fiber through to this ascending fiber. And then lastly, opiates can have an effect on the limbic system. You know very well from the effects of opiates such as heroin, which give certain drug users a high, that they have an emotional effect. And one of the ways that opiates work is make patients less concerned about the painful stimuli they're receiving. So let's now look at paracetamol. Paracetamol is not an NSAID. It's not an NSAID because it's not anti-inflammatory. And we don't completely understand how it works, but it probably inhibits, it's thought it inhibits an isoform of cyclooxygenase called COX-3 and works somehow in the central nervous system, but the details of that remain to be fully explained. It is important, though, to note before we go on that paracetamol is not working by inhibiting COX here in the periphery. Okay, let's now take a look at some of the sensory fibers that are involved in transmitting these signals. And the first one are the A-alpha fibers and the A-beta fibers. These actually aren't involved in pain transmission. A-alpha fibers are involved in proprioception, which is basically the knowledge of where your limbs are, and they have a very low threshold for activation. And A beta fibers are involved in creating the sensation of touch, and again they have a low threshold for activation. So it doesn't really, you want to be able to touch things and feel them very easily. So you want a low threshold so you can got some sensitivity in your ability to feel things when you touch them. In contrast, the pain fibers have a high threshold for activation, so you need a strong signal to switch them on, because we don't want to just touch something and then experience pain. That wouldn't be helpful at all. So the pain fibers have a high threshold for activation, and they fall into two classes: the A delta fibers, and they respond to a sharp pain, and they very rapidly transmit pain fibers up to the central nervous system. They're myelinated, so they can send signals very quickly. In contrast, the C fibers are not myelinated, and so if you go back and look at how action potentials are transmitted, you'll remember that if they're not myelinated, the signals conducted more slowly down an axon, and as a consequence, these fibers conduct the pain signal more slowly, and they transmit a slow throbbing pain. And you all have had experience of that when you've stubbed your toe, for example. You get an initial sharp pain, and then a little bit later another pain comes along. And that's because the C fibers are transmitting that second signal a little bit later. So now let's look at some of the ways in which these nociceptive fibers can be activated. So these are the fibers that are going to send the signals into the central nervous system. So there's got to be a way for them to detect the painful stimuli. And in some cases, they can be directly activated. So if you go and bang a limb into a solid object and it hurts, that's not because you've got a receptor for that solid object. The fibers are probably being directly stimulated by the impact with the solid object. So some fibers can be activated without there being a specific receptor to turn the fibers on. In other cases, though, there are receptors that respond to specific signals. And these are the TRPV channels. And these let in cations. If you remember, cations are positively charged, and because they're positively charged, when they enter the neuron, they depolarize them, and therefore they activate the neuron, they stimulate the neuron. So TRPV1 responds to heat and acid and capsaicin, which is a chemical found in peppers. TRPV2 responds to higher heat. TRPV8 responds to cold and methanol. TRPV1 responds to very cold situations. And then TRPA responds to mechanical stimuli. It's not that I want you to go and remember these receptors in particular. The point I'm trying to make is that there are some receptors that respond to certain signals, or in other cases, fibers are directly activated. It's probably worth knowing about these receptors, though. These are purinergic receptors. That means they respond to purine. And if you recall, ATP is a purine. If you imagine a cell being damaged, well, cells contain a high concentration of intracellular ATP, about 1 millimolar. So when the cell ruptures, it releases ATP, and it can bind to these P2X or P2Y receptors on nociceptive fibers and activate them. So that's a direct response to damage. And ASIC is the acid-sensitive ion channel. This is actually responds to low extracellular pH. So, for example, if you've done a lot of exercise and lactic acid has built up under hypoxic conditions, then the reason you're feeling pain is because the acid pH is activating the acid-sensitive ion channel, and then that's activating one of these nociceptive fibers. So here are some of the NSAIDs. These are the most commonly used NSAIDs in the UK, and we'll talk about each of these in turn. Now, as we discussed, NSAIDs work by inhibiting cyclooxygenase. I want to make a distinction between two types of cyclooxygenase. One is called COX-1 and the other is called COX-2. So these are separate genes. There are different isoforms of cyclooxygenase. They carry out the same reaction, so they both take arachidonic acid, and arachidonic acid can be produced from secreted phospholipase A2 that's in the extracellular space, cleaving phospholipids, producing arachidonic acid, and then that arachidonic acid is a substrate for cyclooxygenase, and that produces prostaglandins. And remember, those prostaglandins then sensitize the nerve fibers to painful stimuli. So there's cyclooxygenase. And the difference between cyclooxygenase 1 and cyclooxygenase 2 is that cyclooxygenase 1 is widely expressed constitutively. That means to say it's switched on all the time. It's expressed continually. And it plays a role in protecting the GI tract. So if you recall from your GI lectures, it regulates the proton pump that secretes protons into the stomach, as well as it regulates the production of mucus that's protective. It's involved in ensuring vascular function, and it's also involved in regulating platelet aggregation. If you go back and look at your lectures on the cardiovascular system, you see that's involved in platelet activation. It also plays a role in kidney function because prostaglandins regulate the perfusion of the kidney by regulating the dilation of the afferent arteriole that comes into the glomeruli. Okay, so that's COX-1. COX-2, it's expressed continually in some tissues. That's what I mean by constitutive. It's always been expressed. For example, in brain and kidney, and that's going to become important. The fact that COX-2 is expressed constitutively in kidney will be important when we start talking about a class of compounds called COXIBs, and we're looking at some of their adverse effects. That's mediated by the expression of COX-2 in the kidney, and it's also expressed in bone. But the biggest difference between COX-2 and COX-1 is the expression of COX-2 in most tissues is inducible. So it's induced during inflammation, and when it gets inflammation, when there are pro-inflammatory signals, the expression of cyclooxygenase 2 is increased, and then that drives the production of prostaglandins. And indeed, if you recall, glucocorticoids are anti-inflammatory, and one of the ways that glucocorticoids inhibit inflammation is by preventing the expression of COX-2. So what this tells us immediately is if you were to have drugs that are selective for COX-2 over COX-1, you could have drugs that could potentially treat pain or inflammatory pain without having these gastric effects, because the gastric effects are mediated by COX-1. I'd like to take a little while to look at some of the biological roles played by prostaglandins. The reason I want to do this is that NSAIDs, of course, block the production of prostaglandins, and if by understanding the role of prostaglandins, then we can understand the therapeutic use of NSAIDs and the adverse effects that are observed when you give a patient an NSAID. So prostaglandins, for the most part, bind to G protein coupled receptors, and they play a large range of functions, essentially as signaling molecules. And so, for example, prostaglandin E2, as I've mentioned already, increases the sensitivity of nociceptive fibers to painful stimuli. So they don't cause pain. So prostaglandin E2 does not cause pain on its own. It just increases the sensitivity of nociceptive fibers to painful stimuli, so they're more easily activated. Prostaglandins also play a role in regulating temperature, patient's temperature. So the body tries to maintain what's called a set point. So in other words, the body tries to regulate itself to a certain temperature, and that is controlled through the hypothalamus. And prostaglandin E2 actually helps control that set point. And sometimes when patients are exposed to a pyrogen, and that might be from an infection, so pyrogen is something that increases body temperature, that stimulates the production of prostaglandin E2, and that elevates the set point that the body's trying to maintain, and so the body actually ends up with a higher temperature, a fever basically. So by blocking this induction of PGE2 by pyrogens, you can reduce the set point, and as a consequence, the patient's body temperature decreases. Obviously, prostaglandins play a significant role in inflammation, and that's been covered elsewhere, so I'm not going to go into it. Prostaglandins also play a role in respiration. So, for example, prostaglandin E2 can cause apnea, and prostaglandin D2 can cause bronchoconstriction. Then there are a number of roles of prostaglandins in the GI tract. So, for example, regulating acid secretion and mucus production, all of which regulate the sensitivity of the GI tract to the acidic conditions there. We've seen previously that prostaglandins play a role in platelet aggregation. Go back and look at your previous lectures on that. But basically, if you inhibit NSAIDs, you inhibit COX in platelets, you can inhibit platelet aggregation, and we'll look briefly at the mechanism of that on the next slide. Prostaglandins play a role in the kidney because prostaglandins can cause vasodilation, and when they cause vasodilation in the afferent arterioles, then that increases renal perfusion, and so you get more blood going into the kidney and greater glomerular filtration taking place. And as I said, the prostaglandins can also cause vasodilation. This is just a recap on material that you've seen before, so you should be familiar with this, but it's important to just have a look at it again briefly. So here we've got cyclooxygenase 1. This is in the GI tract. So this is a cell lining the GI tract. This is the lumen of the GI tract. Cyclooxygenase 1 produces prostaglandins, and PGE2 binds to the PGE2 receptor, and that inhibits the proton pump that prompts protons into the lumen of the GI tract. So if you've got PGE2 being produced, then the proton pump is inhibited. However, if you come along with a cyclooxygenase, reduce the production of PGE2, you lose that inhibition. So you're promoting proton being pumped into the lumen of the GI tract, and then so you've got a greater acidity arising in the GI tract, and that can then contribute to damage to the gastrointestinal tract. And that's all coming about because you block the production of the prostaglandins by cyclooxygenase 1. At the same time, other prostaglandins can regulate the production of bicarbonate in mucus secretion, and because that's protective to the GI tract, then when we lose that by inhibiting cyclooxygenase, that can potentiate the damage induced by the more acidic environment. So you can see then that NSAIDs can promote GI damage, and that can actually lead to GI bleeding. Now, if you remember from your lectures on platelets, cyclooxygenase produces thromboxane A2 from arachidonic acid, and that can feed back, activate the thromboxane A2 receptor, and if you follow this all through, that ultimately leads to the integrin GP2B3A being activated and it binding fibrin and causing platelet aggregation. So if we block cyclooxygenase, we can block platelet aggregation. And you're going to see this is all going to come important in just a little while. Let's just look at some other functions of NSAIDs. This is going to become important in just a few seconds. So NSAIDs, of course, can have activity in the kidney. So here we've got NSAIDs blocking the activity of COX, and so reducing the production of prostaglandins, in particular prostaglandin I2, prostacyclin. And that's important in causing dilation of the afferent arteriole coming here into this glomerulus, and so it maintains renal perfusion. It helps by causing the dilation here, helps the blood get into the glomerulus and drives glomerular filtration. So if you come along with an NSAID and block the production of prostaglandins, prostacyclin I2, then that leads to a loss of this arterial dilation, and it reduces glomerular filtration. And that, go back and look at your lectures on cardiovascular pharmacology if you're struggling to understand that. I went through it in some more detail there. NSAIDs are also important to think about in other cardiovascular settings, so particularly in hypertension and heart failure. So because NSAIDs reduce renal perfusion, they can cause fluid retention, and if you get fluid retention, obviously that's going to exacerbate hypertension, and it's also going to make it harder for the heart to now pump, and so that makes heart failure worse because there's now more fluid around for the heart to have to deal with. So heart failure gets exacerbated as well. And at the same time, NSAIDs, because they inhibit this vasodilation, there's now increased vascular resistance, and that also pushes up heart blood pressure, as well as making it harder for the heart to pump against the increased resistance. So you can see there's an important role of NSAIDs that has to be considered in patients with hypertension and heart failure. So the first NSAID we nearly need to think about is one you're all familiar with, aspirin. It was developed a long time ago, 1920, and it's both analgesic, antipyretic, so it lowers fever, and it's anti-inflammatory. And it works by inhibiting cyclooxygenase 1 and 2, and it does so irreversibly. So here's aspirin, and what it does is it acetylates cyclooxygenase. So there's cyclooxygenase. It actually transfers the acetyl group here to a serine, so that X is actually an OH. It transfers that acetyl group to a serine residue in cyclooxygenase, and that then blocks the active site. And so the active site is blocked, arachidonic acid can't get in there, and as a consequence, COX can't make prostaglandins. It's recommended for use in treatment of pain in a number of conditions, gout, rheumatoid arthritis, headache, and many others. It's also potentially useful in cardiovascular disease, as we saw in our previous lectures, and it's also thought that it might be useful in the treatment of colon cancer, where it's been suggested that daily aspirin might decrease the incidence of colon cancer. At normal doses that are used to treat pain, it's primarily cleared by conjugation and renal excretion, and it's got a half-life of around about 4 hours. But at higher doses, I'm talking about more than 4 grams a day, it can also be anti-inflammatory, and at that point its kinetics changes. So instead of being eliminated with a half-life of 4 hours, suddenly we find that the metabolic processes are saturated, and it's no longer eliminated with a half-life of 4 hours. The half-life now goes up to 15 hours, and it now undergoes something called zero-order kinetics. In other words, the rate of elimination is constant. It's not dependent on the amount of drug that's present, and that's because the liver metabolism has now been fully saturated, and so the drug is just being peed out as fast as it possibly can, but there's no further liver metabolism that can take place as you go to higher doses, so the rate of elimination remains a constant. Adverse effects, well, primarily GI bleeding. If you remember, we saw that COX-1 has a gastroprotective role. So if you inhibit COX-1, then you run the risk of causing GI bleeding, and that's then one of the adverse effects associated with aspirin. But it can also be useful to know that, because you can use that to inhibit platelet function. And as I said, go back and look at your presentation on the cardiovascular system. But of course, sometimes this can lead to prolonged bleeding, which isn't always helpful. A significant percentage of patients can be hypersensitive to aspirin, and they should avoid it. And obviously, because the effects on inhibiting platelets, then it's useful to avoid the drug before surgery. Okay, I'd now like to look at other NSAIDs. And I don't need you to learn the structures. I'm just trying to make a point here. If you go and look at anything on any book on NSAIDs, you very often see that they're broken down into propionic acid derivatives or acetic acid derivatives. And the reason they're called that is this 3-carbon unit here is propanoic acid or propionic acid, a slightly older name. So it's got 3 carbons, and you can see it there, there, and there. So these drugs, ibuprofen, naproxen, and flurbiprofen, these are propionic acid derivatives, whereas indomethacin and Solindac have got acetic acid, so 2 carbon. These are acetic acid derivatives, and so indomethacin and Solindac acid are referred to that way, and so they're distinct from the propionic acid derivatives. That's just so you can understand where this terminology comes from. Let's now look at some of the propionic acid derivatives. So these are inhibitors of COX-1 and COX-2. Ibuprofen and naproxen are some of the most common ones. And I'm not suggesting that they've got equal affinities for COX-1 and COX-2. I'll show you in a later slide that they differ somewhat. But they are all capable of inhibiting COX-1 and COX-2 to some extent. So they can, because they're NSAIDs, they can be used as analgesics, anti-inflammatory, as well as antipyretics. And so there's a number of uses out there, for example, back pain or arthritis. And one of the good things is that these drugs have relatively little effect on platelets compared to aspirin, presumably because aspirin is irreversible and these drugs are reversible inhibitors of COX-1 and COX-2. Naproxen's got some advantages in that it's more potent and it's got a longer half-life, and that means you can use it less frequently, which is helpful, and it's often used, for example, in the treatment of arthritis. Now, because these drugs are a little bit less likely to inhibit COX-1 than aspirin, and because they're reversible, they have less GI effects than aspirin, but they still do have some GI effects. So they do still cause some GI bleeding through the mechanisms I showed you on the previous slide of getting rid of the mucus secretion, inhibiting the bicarbonate secretion, and promoting the activity of the proton pump. And you can actually list the risk of these different NSAIDs at causing GI bleeding. So ibuprofen is the least likely to do it. Diclofenac, indomethacin, and piroxicam, we get to the end here, these are even more likely to do it. These aren't all propionic acid derivatives. I've just compared different NSAIDs, but what you can see is ibuprofen, which is the propionic acid derivative, is one of the least likely to cause the GI bleeding. If you've got an NSAID that's causing GI bleeding, or you're worried it might cause GI bleeding, and remembering that that is in part driven by the activation of the proton pump, one of the things you can do is include a proton pump inhibitor alongside the NSAID in therapy. So the NSAID switches on the proton pump inhibitor, the NSAID switches on the proton pump if you like, and that causes the GI bleeding. But if we add in a proton pump inhibitor, that can suppress or reduce the risk of GI bleeding, and that's particularly important if the patient's going to be taking an NSAID for a long period of time. Some cautions. Well, we want to avoid these drugs in renal insufficiency. Please go back and look at the previous slide. As I showed you, NSAIDs can alter kidney function by inhibiting renal perfusion, by allowing that afferent arteriole to constrict, or promoting constriction of the afferent arteriole. And also we want to be a bit cautious about using these drugs in hypertension. If you recall, because of the effects on the renal function, you get fluid retention, and because the effects on because of their vasoconstrictive effects, they can exacerbate hypertension. Try to avoid them in pregnancy if we can. Paracetamol might be a better alternative. And then some contraindications. If patients have got active peptic ulcers, or you think they're highly likely to have GI bleeding, then obviously you don't want to use these drugs because it just makes the situation worse. And we don't want to use it in a patient who's got heart failure. Please go back and look at the previous slide. Remember, these drugs are going to promote fluid retention, and therefore that would make heart failure worse. And then drug interactions. You don't want to use it alongside an anticoagulant, or you might want to you might want to modify how you use the drug, because if you use it with an anticoagulant, then you've got a combined pharmacodynamic effect. Both the anticoagulant and the NSAID are likely to increase GI bleeding. So let's look at the acetic acid derivatives now. So we're talking here about indomethacin and Slindac. Again, they are reversible COX-1 and COX-2 inhibitors. Although they've got different selectivities for COX-1 and COX-2, indomethacin is actually much more selective for COX-1 over COX-2. With Slindac, it's flipped the other way around, and it binds a little bit better to COX-2 compared to COX-1. Some of the advantages of these: indomethacin is very potent, and Slindac has got a long half-life, or at least it has an active metabolite that's got a long half-life, which means that it doesn't have to be dosed so frequently. So those are key advantages of these acetic acid derivatives, but the disadvantages are that the adverse effects are quite marked. So the gastrointestinal effects we talked about, the risk of GI bleeding, that's quite common for that to occur. And then it's also common for there to be CNS effects. So with Slindac, there's a risk of dizziness, headache, and nervousness. And with indomethacin, there's reports that it can exacerbate depression, epilepsy, and Parkinson's disease. So the adverse effects are not to be taken lightly. And these are generally not used unless NSAIDs are proven ineffective. And certainly we'd want to avoid them in severe heart failure or in cases of patients with existing peptic ulcers for the reasons we already talked about that exacerbate these situations. And diclofenac is also an acetic acid derivative, but it's more COX-2 selective than the other acetic acid derivatives, and that makes it suitable for long-term treatment of arthritis, and it's also used in the treatment of back pain. Then the next set of drugs are called the oxycams, and these were developed to try and make drugs that are more COX-2 selective to try and move away from the GI effects of inhibiting COX-1, and that was achieved with meloxicam, which is tenfold more selective for COX-2 over COX-1, and correspondingly it's seen that it causes less GI irritation because of that. Piroxicam, not quite as good as meloxicam, it inhibits both COX-1 and COX-2. And another advantage of these drugs is that because they've got long half-lives, they can be used once daily. So I thought I'd just show you at this point this diagram that's taken from the publication shown at the top of the slide, which I'd recommend taking a little bit of a look at. It's quite helpful to understand the importance of COX-2 over COX-1 selectivity. And what it shows is some of the drugs we've talked about, and it's plotted them in terms of their relative selectivity for COX-1 over COX-2, and then plotted it as a log of the IC50s for COX-1 and COX-2. So a log of 1 is 0. So 1 means the drug binds to COX-1 and COX-2 with equal IC50s, because one IC50 divided by the other IC50, the IC50 is the same. That's 1, and the log of 1 is 0. So 0 means that the drug binds to COX-1 and COX-2 equally. Then moving over this way, 1, it's a log, so that means the IC50 for COX-1 is a tenth of that of the IC50 for COX-2. In other words, it's 10 times more potent inhibitor of COX-1 than COX-2. So indomethacin preferentially, not quite 10 times, but almost 10 times preferentially inhibits COX-1 compared to COX-2. Whereas if we go over this way, this means that the drugs inhibit COX-2 10 times better than COX-1. Or here, if we get up to 10 to minus, we get to minus 2. That's 10 to the minus 2. That means the drugs inhibit COX-2 100 times better than they inhibit COX-1. More potently is a better word to use. So if on this scale, minus 2 means the drugs inhibit COX-2 100 times better than they inhibit COX-1, 100 times more potently than they inhibit COX-1. And so what you can see looking at this then is that aspirin actually binds COX-1 better than COX-2, which is why you've got all those nasty GI effects. Naproxen and ibuprofen are a bit better, but it's not until you get over here to piroxicam and things like diclofenac that you start to get some selectivity for COX-2 over COX-1. And then there's meloxicam, which I've already talked about, which is really, as I said, tenfold selective for COX-2 over COX-1. And then there's two other compounds I want to talk about on the next slide, rofecoxib and celecoxib. They're really quite selective for COX-2 over COX-1, and you think about this drug here, you think it's almost 100 times more selective for COX-2 than COX-1, so that sounds like it ought to be a really good drug, but you're going to see there's some problems with that drug. In fact, it's no longer on the market, and celecoxib is still on the market, and you'll see why in the next slide. So this class of drugs are called the COXIBs. And as I suggested on the previous slide, they're relatively selective for COX-2 over COX-1. And the idea is that gets you away from the risk of GI bleeding that's caused by inhibiting COX-1. And these drugs worked very well for a while until it's found that a number of them, rofecoxib and valdecoxib, were linked to heart attacks and to stroke. And that led to these two drugs being withdrawn. And so it's not clear whether it's a problem with the whole class of drugs or whether it's just these two. So that's led to quite some caution with the use of the COXIBs. And it's recommended that they be used, if they are used, they're used at a low dose for as short duration as possible. And the drugs that are still used are celecoxib and toricoxib. And they're useful in patients where you need the analgesia, but you've got a high risk of GI toxicity. So you need to avoid a drug that's going to cause GI effects. You need to get the analgesia but you've got to stay away from inhibiting COX-1, so that then they can be useful. But again, you need to use them at a low dose for short duration as possible. So that though, for example, you can use them in arthritis, you wouldn't want to use it for prolonged use because of the potential for the myocardial infarction and stroke. It actually might take with these drugs a number of weeks for the analgesic and inflammatory effects to kick in, so that's worth knowing about. They're metabolized by 2C9 per cytochrome P450, and you see that's going to be reflected in some things we'll see on the next slide. And they've got a half-life of about 11 hours, which allows once daily dosing. So some of the adverse effects, they can still cause some gastric irritation, because although they're preferentially able to bind to COX-2 over COX-1, there's still some COX-1 inhibition, so they still can cause gastric irritation, and they can still cause renal effects. And remember I said that COX-2 is expressed constitutively in the kidney? Go back and look at the slide earlier on when I was talking about when I was comparing COX-1 and COX-2. You see that I said COX-2 is expressed in the kidney, and there's the reason that these drugs still have effects on the kidney. So bearing that in mind, you'd want to be cautious about using it in patients who've got renal and hepatic impairment. Obviously in renal impairment, then you wouldn't want to worsen the kidney function. And bearing in mind that this drug's metabolized by P450, then if patients got hepatic impairment, you'd be worried about elevated plasma levels, potentially leading to that myocardial infarction or stroke. Otherwise, the contraindications are similar to other NSAIDs, and if patients have got an allergy to sulfonamide, you shouldn't use them. Unsurprisingly, if you use it alongside another drug that inhibits 2C9, then you run the risk of increasing the serum levels, and you should be thoughtful about that because, as I said, these drugs have been linked to myocardial infarction and stroke. So if you think the patients could be at risk of that, be cautious. And then they, surprisingly, I suppose, they worsen inflammation in some conditions. They worsen bowel inflammation in patients who've got ulcerative colitis and Crohn's disease. And you shouldn't use it in patients with ischemic heart disease, heart failure, and vascular disease. And from what we've said so far about the function of these drugs or of NSAIDs in the cardiovascular system, that should be fairly straightforward to understand. Let's turn now to paracetamol, which is called acetaminophen in the US. It's important to notice that this isn't an NSAID, and the reason it's not an NSAID is it's not anti-inflammatory. So it'll work as an analgesic, it will reduce fever, in other words it's an antipyretic, but is not anti-inflammatory. Its mechanism of action actually is bizarrely unclear. We don't really know how paracetamol works, at least at the time I'm recording these lectures. It's thought that it might inhibit an isoform of COX called COX-3 in the central nervous system, but it's not really potent inhibitor of COX-1 or COX-2. So it doesn't have any effect on platelets or clotting time, which is helpful, and it doesn't really have any GI effects or doesn't have substantial GI effects. So it's a useful analgesic because it avoids those problems. So you can use it to treat pain, and as I mentioned earlier on, it's better taken regularly rather than as needed. So taking it in anticipation of pain, if you like, rather than when the pain crops up. And if necessary, opiates can be added on to improve its effects. And the reason that works so well is the drugs work by different mechanisms, and as a consequence that allows synergistic effects to take place. And by synergistic I mean more than additive effects to suppress the pain. So we've got very few ADR, as I said. You don't get the GI irritation effects, and it can be generally it's usually okay to take in pregnancy. It is metabolized in the liver, and as a consequence you need to be cautious about giving it to patients with liver problems. And one of the reasons is it actually causes, if you take enough of the drug, it actually causes liver toxicity, which is called a self-perpetuating problem, I suppose. And that leads to it being one of the most commonly used drugs taken in deliberate overdose. And a patient who's taken a large dose of paracetamol should be sent to casualty to go and have their plasma paracetamol levels determined. In terms of drug interactions, there is some debatable evidence that it interacts with warfarin to increase the clotting time, but that evidence is contradictory and it's not clear how it would happen anyway, so whether that's real or not isn't really sure. Okay, the last class of drugs we're going to look at are the opiates. And opiates work through binding to opioid receptors. So opioids are peptides, they're the endogenous signaling molecules, and opiates are alkaloid bases. In other words, drugs such as morphine that also bind to the same receptors. So the receptors have three subtypes. They're called mu, delta, and kappa. They're all G protein coupled receptors, and in general they inhibit neuronal activity. And if we look at the diagram over here, we can see how they might work. So opiate receptors can inhibit potassium channels. So this is a neuron. So imagine this is a nerve fiber coming into the dorsal horn of the spinal cord, and it's going to release a neurotransmitter, and quite often that would be something like glutamate. That's going to bind to a postsynaptic receptor, and this is then going to transmit the pain signal up towards the CNS. So the pain signal, if you like, is coming in here and moving this way, and glutamate is a neurotransmitter. It's transmitting the signal from the presynaptic neuron to this postsynaptic neuron. So in the postsynaptic neuron, opioid receptors can activate potassium channels. And because potassium is positively charged and its concentration is high in cells, when that channel gets opened up, it causes potassium efflux, and that then causes hyperpolarization of this postsynaptic membrane. And as a consequence, it's harder for the neurotransmitter to generate an action potential because the membrane has been hyperpolarized by the potassium channel opening. At the same time, presynaptic opioid receptors can inhibit calcium influx through calcium channels, so it inhibits these calcium channels. So normally the action potential rising, so the nerve fiber's been stimulated by some noxious, painful stimuli, it's created an action potential, and that normally would open the calcium channel and cause calcium influx, which drives the neurotransmitter release. But the opioid receptors can inhibit the activation of that calcium channel, so they block the calcium influx, and so that blocks the calcium release the calcium influx driving the neurotransmitter release. So the opiates can block both presynaptic effects by blocking neurotransmitter release, and they can block postsynaptic signaling by causing membrane hyperpolarization. So in both cases, the opiates are working to prevent the pain signal being sent up the spinal cord. Now, if you look at the other functions of opioids, and some of them are presented here on the left-hand side, if we go through these, you can understand the adverse effects of giving opiate drugs to patients. So, sure, they have a role in regulating pain transmission, and that's why inhibiting opioid receptors acts as an analgesic. But because opioids also regulate pupil diameter, you see that some opiates often cause patients to have constricted pupils, and they can also cause respiratory depression, and opiates can be used to treat cough. And you know very well that opiates have emotional effects. That's why heroin users take the drug, and so you expect that opiates will have a euphoric effect on patients who take them. Now, there are a whole range of classes of drugs, so the pharmacology gets kind of interesting here. So we've got drugs that are full agonists, such as morphine, fentanyl, and sulfentanyl. Then we've got drugs like codeine, that's a prodrug. So that actually gets metabolized to morphine. So codeine's methylmorphine, it gets demethylated, and 10% of it's demethylated to morphine. But it's only 10%, so it's much less effective, much less efficacious than morphine itself. And then we've got what we call mixed agonists and antagonists. So these are drugs that can act as agonists at some of these receptor subtypes, but antagonists at others. And an example of that is pentazocine. And then there are other drugs which act as partial agonists. An example of that is buprenorphine. And you see in a minute that that's actually quite important. That's therapeutically important. So all the stuff I taught you in the second year about partial agonists, that's therapeutically important. So we can use morphine, for example, to treat pain. Codeine can also be used to treat pain, but it's also used as an antitussive, and it's also used to treat diarrhea. So morphine's an agonist at the mu opioid receptors, and it's used in patients who are suffering from severe pain. Because it's got poor oral bioavailability, it's generally delivered by IM or IV routes. And if you need to ensure a prolonged analgesia, then there are controlled release preparations to achieve that. Now, if you look at some of the adverse effects, this just reflects some of the biological functions of opiates I showed you in the previous slide. So please go back and look at the previous slide again, see what opiates do, and then you should be able to understand some of the adverse effects. So, for example, the behavioral effects, the effects on the limbic system lead to patients suffering, I'm not sure if suffering is the right word, but experiencing euphoria. Very important, opiates can cause respiratory depression, so they reduce the tidal volume and they reduce the frequency of respiration. That can be quite serious if it's extreme. It can cause thinning of the narrowing of the pupil, vomiting, constipation. Don't forget these drugs are used to treat diarrhea, so it's not surprising that they can cause constipation. They can reduce body tension and cause hypertension as well. Now, one of the issues with opiates is that they can also cause dependence and they can cause tolerance. So what happens here is if you give a patient an opiate, the receptor signaling system can become desensitized. So the receptors get phosphorylated and they're less able to transmit signals. And also the number of receptors on the cell surface can be reduced. That's called receptor downregulation. And now that means you've got less opiate receptors available to respond to drugs such as morphine. So the patients become tolerant to the drug. That means to say the drug is less effective. And so you need to use progressively higher and higher doses. So that gives rise to something called tolerance. But now what happens if you take the drug away suddenly? The patients have now got fewer opiate receptors there. And their body has got used to being continually exposed to the opiate. But now they're trying to function without the opiate, but they've got a few receptors. And that leads to withdrawal symptoms. And so, if you like, the patients have become dependent on the continued presence of the opiate because they've been continually exposed to it, and that's led to receptor downregulation. So this is one of the reasons why patients become addicted to opiates. They become dependent on them because of the changed receptor number. Okay, so contraindications, well, opiates are contraindicated in respiratory depression or severe asthma. This should be obvious because opiates have a respiratory depressive effect on their own. And when you think about drug interactions, because these drugs inhibit neuronal function, then you should, for the most part, think about what effects they might have with other CNS drugs that depress CNS activity. Alternative to morphine is oxycodone, which is a semi-synthetic derivative, and it's available in high-dose formulations for patients who have become tolerant to opiates, and it's particularly of use in palliative care. So codeine and dihydrocodeine are prodrugs. They're demethylated to morphine, but only a fraction of the drug gets demethylated to morphine, and so they're less effective as analgesics than morphine. But that has its advantages too, because only a fraction of it gets converted to morphine, so it's less likely that patients are going to become dependent on codeine, and as a consequence, you can use codeine to treat other diseases such as an antitussive to prevent cough, or you can use it to treat diarrhea, and you've got a less of a concern that the patients are going to become dependent on the continued use of the drug. Now, because they're less effective than morphine, you might need to combine codeine with another drug such as paracetamol to get adequate analgesia. Now, in terms of the adverse effects that patients have experienced, it depends upon the dose of codeine. So relatively low doses can cause constipation. It's only when you go to the high doses, such as 60 milligrams, that you start to see the typical adverse effects that we described on the previous slide. Then another opiate is pethidine. Pethidine is particularly useful in childbirth because it's got a relatively short half-life, and that means when the newborn child emerges, the drugs metabolize quite quickly, and so you're less likely to get respiratory depression in the newborn child. If you used an opiate with a long half-life, you'd run the risk of the newborn child suffering from respiratory depression. But pethidine avoids that because of its shorter half-life, so that's quite useful. Okay, so let's now look at buprenorphine. As I said, buprenorphine is interesting because it's a partial agonist at the mu-opioid receptor. And that's useful because it's a partial agonist, you're less likely to get some of the adverse effects and the dependency that you'd otherwise get with a full agonist. So even though it's a partial agonist, it's sufficient to cause, it can be sufficient to be an analgesic in patients who have never been treated with morphine before, so they haven't had a chance to become tolerant to it. So it's a low efficacy agonist, but if the patients are naive to morphine, then the analgesia may be sufficient. It can also be used to treat patients who have become accustomed to morphine use, because rather than quickly withdrawing it, you can switch firstly to a partial agonist and then withdraw that more slowly, and that kind of eases the patients off the drug, if you like, by going to a lower efficacy agonist first. So it's useful in opiate detoxification. In terms of adverse effects, you see the same thing. You get less sedation, less respiratory depression, less hypertension, less euphoria, less risk of abuse, all because it's a partial agonist. It's less effective at the mu-opioid receptor. Okay, tramadol is a opiate agonist, but it has a different chemical scaffold. It doesn't have the classical opiate chemical structure, even though it acts as an agonist at the mu receptor. Although it can act as an analgesic, it also has effects on serotonergic and adrenergic neurotransmission. And because those systems are also involved in pain transmission, that means that tramadol can inhibit or can act as an analgesic through opiate, serotonergic, and adrenergic systems, and that means that it causes analgesia by multiple pathways. So if you like, you can use a lower dose than you would otherwise need at the opioid receptor, and so you get less respiratory depression because you've got a lower opiate dose, but you're getting extra analgesia from the effects on the serotonergic and adrenergic systems. So it can be used to treat moderate pain, but it can cause seizure, and that's probably because its effects on the serotonergic and adrenergic systems. And this is a particular problem in patients who are taking other drugs that affect the serotonergic and adrenergic systems, such as SSRIs or tricyclic antidepressants. But because it's got a reduced, it's less likely to have opiate effects, then you don't get too many of the opiate side effects either. Then the last set of drugs I want to talk about under opiate analgesics are fentanyl, sufentanil, and alfentanil. These again are not opiates in terms of their structure, but they are agonists again at the mu receptor. They're very lipophilic, and so they're very bioavailable, and they're very often used as analgesics after anesthesia. So as you see in electron anesthesia, very often after you've anesthetized the patients, you need to provide analgesia as they wake up, and fentanyl or alfentanil can be used for that. They can also be used as a way to treat what's called breakthrough pain. So breakthrough pain is pain that is experienced by a patient who's normally been controlled, or the pain's normally been controlled by some other medication, but this intermittently breaks through that pain control. So they have episodic pain that breaks through the normal pain control, and adding fentanyl onto that can be useful to treat that breakthrough pain. Adverse effects include hypoventilation. So the last drug I want to talk about is naloxone. Naloxone is not an analgesic, it's an opiate receptor antagonist, so it blocks the effect of opiates. And that makes it useful to treat patients who have overdosed on opioids, to treat the coma, or to treat respiratory depression.